So our last speaker for this morning's session is Dr. Robert Bredt. He is the Medical Director of the Texas Medical Board. He is a board-certified pathologist and runs multiple laboratories. He is going to speak to us about a very important topic, the Texas Medical Board rules regarding pain management. Dr. Bredt.
Wasn't sure if I'm going to be able to see that, so. Good morning, everybody. I guess I'm the last thing standing between you and lunch, so I'll go through all of these things and make it clear for you. Been asked to speak today on the rules on pain management and pain management clinic. It's a topic near and dear to most of your hearts, and I'll be going through a lot of things with this talk. One disclaimer, as a pathologist, pain management is not something I did in my normal practice. Outside of the pain caused by laboratory employees, nurses, hospital administrators, and other physicians, I didn't have a lot of this in my practice. However, with the medical board for the last 4 years, it's been very eye-opening, seeing what's been going on and what is actually going on out there in the real world, seeing examples of both good pain management and pain management that's an issue, and quite frankly, some outright drug dealing. So this is something that the medical board has to deal with. There's a number of laws that have been written, passed by the legislature, that it's up to the medical board to enforce, and so I'll go through some of those issues. Unlike a lot of other areas of medicine, pain management kind of has an overlap, again, because there's such a high incidence or high likelihood of these drugs being abused, these medications being diverted, frank criminal activity associated with these medications. There can be a lot of issues with that. However, the board also has to balance that out with the very essential function that these medications play in the very real problem of patient pain, particularly chronic pain, and I'll get more into that. So we'll talk about pain management. I'll talk briefly about pain management clinics and inspections that we've started doing. Some of the other topics that are common issues not necessarily related to pain management, prescribing to friends and family. I'll go through, if we have time, some of the enforcement process, and then I'll make a blatant appeal to you all if you want to serve as expert panelists to the board to go ahead and contact me. But I'll go into all of that in detail. The issue that we're up with respect to pain management is the high incidence of drug abuse and opioid-related deaths. I don't need to tell you about the recent CDC study looking at a 14-year period of opioid use and drug-related deaths. In that time period, the deaths from drug overdose went up 173%, and opiates even more than that, up 200%. So 3 times the number of deaths occurred in 2014 as occurred in the year 2000. So again, very serious. And now this is either licit or illicit opioid use. But because most of these opioids originate as a valid prescription, which are then diverted, it's important to take that into consideration as well. Going through the Texas Medical Board rules, there's a good indication of the philosophy of the board, and the first sentence in the pain management rules, Rule 170, is the recognition that treatment of pain is a vital part of the practice of medicine, and that patients look to physicians not just to cure the disease, but also to relieve their pain. There's also reassurance in this statement. Physicians should be able to treat their patients' pain using sound clinical judgment without fear that the board will pursue disciplinary action. So again, a reassurance that doing the right thing by your patients, protecting them from both their disease, pain, as well as the issues of overdose and addiction. As long as physicians are doing that and doing that using sound clinical judgment, there should be absolutely no fear of any issues from the board. Again, always like to put in the mission statement of the Texas Medical Board is to protect and enhance the public's health, safety, and welfare by establishing and maintaining standards of excellence in regulating the practice of medicine and ensuring quality health care for citizens of Texas through licensure, discipline, and education. The board president has somebody from the board read that statement every time when we have a board meeting, and we have those board meetings 5 times a year to, again, remind us of what the goals and missions of the medical board is. It's to protect the public's health. Now, again, as a disclaimer, I've been referred to as head of the medical board, and I'm not. The medical board itself is appointed by the governor. There are a total of 19 members, 12 of whom are physicians, and they have 6-year cycles. What I am is the medical director for the board. So there is an executive director, a lawyer, Mary Robinson, who handles all the legal aspects and interfacing with the legislature. My job is to help provide medical guidance to the board, particularly the board staff. Again, the board members who are physicians don't need my help. They are acutely aware of the practice of medicine. But it is these 19 folks who pass the rules, who interpret the statutes that have been passed by the legislature, and my job is to help our board staff, which is about 200 or so folks, implement the intent of both the legislature statutes as well as the board rules. And there are a number of principles of chronic pain that are also echoed in the board rules. First, the recognition that pain is a medical condition that they say every physician, but not usually pathologists, sees regularly. And that patients have an expectations and deserve to have a medical treatment for their pain. And the recognition that the regulatory atmosphere that the board sets up needs to support the ability of a physician to treat pain, and no matter how difficult or complicated the case. And these are all recognized in the rules. However, the board is also charged by the legislature with responsibility, and a responsibility to ensure that the drugs are used in a therapeutic manner, and recognize that harm can result when physicians do not use sound clinical judgment in prescribing drug therapy. Now, this could be any drug therapy, but because chronic pain is such an issue, it's specifically spelled out in the medical board rules. There are very few places in the medical board rules where there are actually guidelines and suggestions for how to treat and what the minimum standards are to meet the standard of care. In most areas of medicine that the board regulates, the standard of care is left entirely up to physician experts. And I'll get into that process later. But with chronic pain, there are actually published regulations and rules that help guide physicians on how to adhere to that standard of care, unlike virtually every other aspect of medicine. There's a requirement of medical records over and above what's required in a standard medical records. As always, medical records must be complete, accurate, and current. But for the treatment of chronic pain, there needs to be a documented and detailed plan, and there needs to be an assurance that that treatment is monitored. And contrary to popular belief sometimes, it's the intent of the board not to impose merely regulatory burdens on the practice of medicine, but to set forth rules that help guide those things that are expected to be found, and a reflection of the standard of care. And again, to reemphasize the definition of standard of care, it's what a reasonable or prudent physician would do in the same or similar circumstances. The standard of care is not a gold measure. It is not perfect care. It is not intended to be the best possible care. It's intended to reflect what another reasonable clinician would do given the same situation. Standard of care may change based on practice. Some things that are not available in rural areas could not expect it to be done, and the standard of care as interpreted by the board and by our experts reflects availability of care as well. So it can be very situational. Oddly enough, standard of care can differ from state to state, can differ in an academic medical program, but it's not specific to a specific discipline or board specialty, but may be specific to those particular circumstances in those particular cases. The ideal physician treating a patient in a clinical setting is what we expect when we look towards the practice of medicine. In reality, what we find out there when we do inspections and raids on some of these clinics where we accompany DEA, DPS agents can be very much different. You find evidence of frank drug dealing operation with a physician associated with these clinics, either supervising the mid-level provider and being in the clinic, getting a bag of paper money once a week, paper bag full of money, or pretty much just delegating to mid-level providers and not being present at all to meet the requirements of the rules. So we find all sorts of things there. We find armed guards, we find money counters, cameras, bulletproof glass, and quite frankly, sometimes a cache of weapons. So again, sometimes what we go in, these sorts of situations, it's very easy to determine that this is not the practice of medicine, this is a criminal activity. But I'll tell you, even physicians that we catch red-handed in these sorts of situations profess their lack of, oh, I didn't know what was going on, I was just trying to do my best. These are underserved patients crossing the border, state lines. I had no idea that they were seeking drugs. I never saw one a second time. So again, it can be quite apparent that what we're dealing with oftentimes is not the practice of medicine, but is criminal activity. And then sometimes there are things that fall in between. Physicians who are misled by manipulative or drug-seeking patients. Again, trying to do what they can or think is in the best interest of the patients, and being caught by unawares. And certainly the board deals with those different situations very differently. And again, the guidelines that the board has published in the Rule 170 as far as pain management helps give physicians some of the guidance and the tools that they need to stay on the right side of this medical care. So what's required in Board Rule 170? There's requirement for evaluation of a patient, a written treatment plan. There needs to be informed consent, an agreement, a written agreement signed by both the physician and the patient for the treatment of chronic pain. Physicians need to periodically review the treatment that's being given and evaluate whether the treatment is successful or not. When appropriate, there needs to be consultation and referral. And of course, all of this needs to be documented in the medical records. Again, things that are fairly common sense, things that virtually all physicians outside of some of the specifics with the treatment plan done with every single patient, but you'll be surprised, or I was very surprised when I saw what passed for medical records and what passed for a physical evaluation in some of these instances. So with evaluation of the patient, at a minimum, a medical history, a physical exam, and the physical exam should be problem-focused, specific to the chief presenting complaint of the patient. That's if you're lucky enough to get only one complaint. Sometimes it's a laundry list of complaints, so the exam may be focused in a number of different areas. The medical record for chronic pain must include a documentation of the nature and intensity of the pain, must include documentation of current treatments that the patient is undergoing, as well as past treatments, any underlying diseases or chronic conditions associated with that. Importantly, the effect of pain on function. There has to be a separate evaluation of the history and potential for substance abuse, and that must be documented. And then you have to be clear as the medical indications for the use of any drugs or either controlled or not controlled substances that you use for the treatment of chronic pain. Things that are left somewhat optional in the rules, and again, it's going to be specific to the individual cases and the individual patient needs, is reviewing the DPS or prescription database, now controlled by the pharmacy board, to be able to look up what the current and past controlled substance use is for the patient with the prescription drug monitoring program. Consider doing a baseline toxicology screen. And if you decide that either or both of these are not required in a particular patient or a particular setting, document in the medical records the rationale for not completing those steps. The treatment plan, a written treatment plan, is required for the treatment of chronic pain, and that should include the medications that are being prescribed and their relationship to the patient's chief complaint. Obviously, the dosage and frequency of the medications, any sort of further diagnostic testing that you plan to do or will do on the patient. If there are other treatments that are planned outside of prescription medication, those other treatments need to be documented and the plans included. You need to include periodic reviews of the patient functioning to determine whether or not the treatment that you're doing is actually of benefit. If patient's pain is 9 out of 10 and has been 9 out of 10 every single visit for the past year, then maybe it's time to relook at that medication, and that medication is not effective in that particular patient. So again, there needs to be written objectives that you're looking at to determine the success or failure of a particular drug treatment regimen. Informed consent for the treatment of chronic pain is also required, and it's like any other informed consent where you discuss the risk and benefits to the use of the treatment, and in this instance, controlled substances. It needs to be signed by either the patient's surrogate or guardian, and needs to be contemporaneous, can't be done after the fact, and needs to be included in the medical record. Now, this informed consent does not need to be a separate written document. It can be documented in the medical record that you've discussed this with the patient and discussed risks and benefits. However, if you do it in that manner and don't have a separate document signed by the physician and patient, then it does need to be, again, contemporaneous and not done after the fact. Pain agreement is also required by our rules in the treatment of chronic pain whenever you're doing extended drug therapy for a patient with chronic pain. And this needs to include the notice to the patient that you're going to be doing laboratory testing, including oftentimes urine drug testing to make certain that they're not taking any other illicit substances or other controlled medications that may interfere with your treatment, as well as to document the fact that they are taking the medications you are prescribing them. Since these medications oftentimes have very high value on the street, many patients are diverting these to other individuals and not taking their medications. So if you have a patient on hydrocodone and every time you do a urine drug screen they're negative for that, that's an indication that they're not taking their medication, and may well be an indication that you may not be able to continue to treat that patient. One of the other additions to the rules is the limit to one physician prescribing controlled substances. This needs to be an agreement between you and your patient. Now again, call coverage and those sorts of situations, certainly on a one-by-one basis can certainly be an exemption to that. But as far as the routine prescription and refills, it needs to be one physician prescribing. Also, should only be one pharmacy that they fill the prescription at. Again, this is up to the patient's own choice. It should not be dictated by the physician. And also, there can be exceptions to this if that particular pharmacy is out of stock of that medication or the patient wishes to switch pharmacies, but they should not be obtaining prescriptions from multiple pharmacies at the same time. Also in the pain agreement should be clearly delineated what constitutes a violation of this agreement by the patient and under what circumstances the physician might choose to terminate the doctor-patient relationship due to violations of the pain management agreement. As I said before, periodic review of the efficacy and side effects of the treatment are required under the rule. Now, there's no absolute requirement as far as time intervals go. In some patients, it may be 1 month. In some patients, it may be 3 months. In some patients who are intermittently taking the medication or not taking it on a daily basis, potentially longer than that. Again, anywhere in the rules, and I'll go ahead and emphasize this again, anywhere in the rules where there's no specifics or it's left up to the physician to meet the standard of care, those whether or not a standard of care is met is assessed by one of our physician expert reviewers. And I'll go ahead and mention it now. Any case that we have for the medical board, again, the medical board is a complaint-driven organization. We don't go out and hunt down physicians and try to figure out who may or may not be violating the rules. The only time that we take actions or potentially take actions, open investigations on physicians, is when we have a complaint to do so. If that complaint involves something that involves standard of care, in other words, it's not a complaint that, oh, I had to wait too long in the waiting room, or the doctor at the jail wouldn't prescribe for me to only be up in the top bunk. When it involves standard of care or care delivered, we always have a physician reviewer initially review the complaint. We have 2 physicians on staff who do so, as well as if there's any merit or potential merit in the complaint and we obtain the medical records, those are reviewed by at least 2 experts who are board certified in the specialty that that physician is practicing in to review those records and determine whether or not the standard of care is met or not met. And again, those are unbiased independent reviewers. While they are compensated for their time, they are not employees of the board. We don't have any expectations of them. We want them to give, their purpose is to give an assessment to the board members, some of whom are not physicians, most of whom will not be board certified in that particular specialty of medicine, what somebody who is specialized in that area feels about the standard of care in that particular case. And so we want to have them give us an unbiased, objective view. If there's no violation of the standard of care, the expectation of the expert is to let us know. And the majority of the cases that come before us in which there is an allegation of standard of care violation, our experts find no violation of the standard of care. And so those cases are subsequently dismissed. Pain management clinics is something that the board established a number of years ago, a requirement that if you're prescribing to patients on a monthly basis, majority of your patients, opiates, benzodiazepines, barbiturates, or soma, that you're required to register that clinic as a pain management clinic. Now, this does not include Suboxone treatment, so that is not included in the numerator. There also are a number of exemptions of clinics that are not required to register, even though they would have met that criteria. Some of these are fairly straightforward, a medical or dental school or an outpatient clinic associated with either of those 2 entities, any hospital or outpatient facility associated with a hospital, hospice, any Texas state or federal facility, and then a variety of nonprofit healthcare organizations also, even though they might meet the criteria as far as the number and frequency of the medication, prescription of those controlled substances, would not be required to register with the board. One of the other little bit more nebulous exemptions is a clinic that's owned or operated by a physician who sees and treats patients within the area of the physician's specialty, who personally uses other forms of treatment, including surgery, even if a prescription is issued in the majority of those patients. This initial exemption was written to prevent, let's say you've got a surgeon in an outpatient clinic who frequently prescribes short-term opiates for post-operative pain. The intent of the board was not to get a physician like that in that setting to be required to register as a pain management clinic. They're not a pain management clinic. They're an outpatient surgery clinic who needs to prescribe outpatient opioid therapy. So again, a clinic like that would not be required to register. Additionally, say an anesthesiologist who is doing injections, personally doing injections, as well as writing prescriptions for pain management, would also not be required to register with the board. Ownership of pain management clinics, they have to be owned by a physician who has an unrestricted license and who is practicing in Texas. There's a number of requirements of the employees who are working in a pain management clinic. All of the employees who have personal contact with the patient need to get at least 10 hours of CME in pain management. and that includes the physician who is seeing patients. That clinic also needs at least 10 hours of CME and pain management a year. The director of such a clinic needs to be present at least a third of the time, and at least a third of the charts need to be reviewed by the director. And as well, they need to follow all of the rules that have to do with chronic pain management in order to be part of the pain management clinic and run a pain management clinic. A pain management clinic director also has responsibilities. In addition to doing the required CME, they need to document the background and training of all the staff. They need to have a written drug screening policy, urine drug screening policy. They have to define some periodic quality measures of the outcomes on their patients. And requirement is to maintain the billing records for at least 7 years since the last visit of a particular patient. So these rules have been established since 2009, and when those rules were initially established, the board had authority to go in and do inspections of those pain management clinics. However, we did not start doing so until 2014, as the legislature did not fund us to do any of those inspections. So really, the number of pain management clinics that are registered with the medical board since the currently is 119. We saw a drop-off of registered clinics once the requirement for inspections were put in place, and we have inspected all of those since we started in 2014. And by and large, in fact, virtually to a clinic, the ones that are registered and that are inspected meet all of the rules and requirements that are in the Texas Medical Board rules. The ones that weren't meeting those are typically the ones that are not registered with the board. So the ones registered with the board do very well. Another topic I wanted to talk about, and this deals both with controlled substances as well as with dangerous drugs, is the concept of prescribing friends or family. My father is an oncologist. Growing up as a kid, he would take care of the family like he would anybody else. When we had strep throats, he would bring home a vial, do a culture on our throats, and if it was positive, would give us a prescription of penicillin. Oftentimes, before it was positive, he'd write the prescription, and then we'd wait and see what the results of those cultures were. He didn't keep medical records on any of this sort of things. He was taking care of us in the old style of a physician-patient. That is not the case these days, at least not the case in Texas. And our Rule 190 has to do, these are violation guidelines, deals with prescriptions of friends or family. And that's the expectations that whenever you're writing a prescription, either for controlled substances or for dangerous drugs, that's anything that needs a prescription, even if you're writing for family members or close personal friends, is that you need to have written records. Needs to be a physical examination, there needs to be an adequate history, and there needs to be documentation of all of that. Gone are the days when you could just write for, again, antibiotics for a potential strep throat, or refill the medications for your wife. Should anybody complain about that, and you didn't keep medical records, you could potentially be subject to discipline by the board. Now, controlled substances, the rules are even more restrictive, and that you cannot write controlled substances even for greater than 72 hours, even if you have done an adequate history, physical exam, and maintain medical records. The expectation is if somebody were to run out of something they absolutely needed, you could write something for immediate need, but that would be limited to 72 hours only. So renewing your son's prescription for Ritalin is no longer, is not for a month, would not be acceptable. Let me go through the enforcement process, and since we have time to do so, we got about half the time done, and I won't take all of the time here. We receive anywhere between 6,000 and 8,000 complaints against physicians a year. Now that's out of a pool of about 80,000 licensed physicians across the state. That's not to say every 10 years every physician would get at least one complaint. These are certainly clustered amongst a large number of high visibility, high frequency physicians, but it's roughly we get one complaint for every 10 physicians a year. Now, the origin of these complaints vary across the spectrum, but the vast majority of complaints are given to us by either a patient, family or friends of the patient, health professionals, or other consumers of health care. So that's well over 2/3 to 3/4 of the complaints we get. About 1/5 of the complaints, 18% or so, are listed there as originating with the Texas Medical Board. These are either a result of, say, CME audits or things that we find in the newspaper, things that we find through other media that we're made aware of that these are complaints that originate with TMB. We get occasional complaints from other governmental agencies. In other words, the nursing board, when they're investigating a nurse, may also find problems with the physician who is supervising them, in which case we would potentially get a referral for a complaint. And then insurance companies make up less than 1% of the complaints we get on an annual basis. As far as the types of complaints we get, 43%, the largest percentage, has to do with quality of care and standard of care. Next largest is unprofessional conduct. This may either be boundary issues with a particular patient. This may be anger or hostility towards a patient or towards the staff. Next largest is crimes and laws. So these are physicians who are convicted of crimes that may or may not have direct bearing on their ability to practice medicine. It may be a DWI. It may be Medicare fraud. It may be domestic abuse. There's a number of crimes and laws that are a breakdown. The other important subset is about 6% has to do with impairment. This is, again, either due to drug abuse or potentially debilitating accident, dementia, some neuropathies. There's a number of things that fall into the impairment issue. It's not to say that every complaint that has impairment is going to be a problem. A large number of these complaints or issues that are brought up are dismissed, and there's no disciplinary action. But as far as the complaints that we originally get in the board, this is the breakdown of those. So again, looking at the complaints in 2014, we had about 6,800 complaints. Of that, a good almost 2,000, over 2,000 of them were immediately dropped, 32%, because they weren't jurisdictional. There either wasn't enough information to follow up the complaint didn't have to do with a violation of the Medical Practice Act, or they did not originate from somebody that we could verify was an actual person. Again, all complaints submitted to the medical board are confidential in that those identities are not released or either by subpoena or to the physician against whom the complaint was registered. However, we do not accept anonymous complaints. There needs to be a real person on the other end of that complaint. So that's an important distinction. So if a complaint is deemed jurisdictional, there's enough information and it falls within the purview of the Medical Practice Act, we then ask the physician for a response to those allegations in the issue. And almost 61% of the time, based on the physician's response, we're able to review the physician's response and decide there's really nothing there. The explanation was adequate in those initial records that were obtained, and so those cases are dismissed as well. So that's another chance for the physician to respond. If, however, there's felt to be merit in those cases are set for an informal settlement conference or an ISC in which the physician and usually their attorney comes down to Austin to explain their side of the story. And even after those ISCs, another 57, almost 60% of those cases are again dismissed at that point. So physicians have a large opportunity to respond. Of those 6,800 complaints we got, we end up with about 10% of those complaints resulting in either a disciplinary order or a remedial plan. Now, as far as my shameless plug goes, is for expert panelists. As I said, with any standard of care complaint, we require that we get at least 2, sometimes 3 physicians if the first 2 don't agree, to give us written opinions and reports on those, whether or not they feel the standard of care was met or not met. These can be a single patient standard of care complaints, of which the records comprise 100, 200 pages, or they can be much larger complaints. In some cases, we've had 30, 40 patient records that needed to be reviewed, and many thousands, tens of thousands of pages of documentation. So each case is different as far as the size and the time commitment. The experts we get are always matched to the specialty in which the physician is practicing, whether or not they're board certified. So if we have a pathologist who's practicing neurosurgery, we're going to have a neurosurgeon review that case. We're not going to have a pathologist review those cases. So typical reviews take anywhere from 4 to 10 hours. They are completely confidential. Your identity is not revealed to the complainant. Even if there is a subpoena for those records, there's absolute statutory confidentiality of those expert reviews. We also occasionally utilize experts as testifying experts. If we have one of those informal settlement conferences and the board says, yep, there needs to be an order and here's the order, the physician has the opportunity to sign that order and agree, yep, I didn't do right, I'll go ahead and agree to that, or continue to dispute it and say, no, I think I was in the right, in which case those cases go to the State Office of Administrative Hearings, or SOA. And there the physician gets yet another chance to respond. And in that situation, our experts actually have to come in and testify and are cross-examined by the physician's attorney and or physician. So in those instances, those experts are not confidential. But every expert has the option of whether they wish to be just a confidential written expert or a testifying expert. Now again, these experts are remunerated at $100 an hour, which is a decent wage for the physician assistants who come in and write reports. Not so good for neurosurgeons who do so. But that's the flat fee. The experts who do this for us are not doing it for the money. They're doing it for a chance to police their own specialty, as well as to vindicate those physicians who are wrongly accused. So those are my appeals to experts, or those who may become experts. Requirements for experts is they have to be currently licensed and actively practicing medicine in Texas. Active practice of medicine is at least 20 hours a week for 40 weeks a year. Required to be board certified, and if you have a time-limited board certification, to maintain that. It can never have been convicted of a crime, imprisoned, or placed on probation. They have to have an acceptable malpractice history. We can't have our experts testifying for the physicians who come across to the board for discipline, so they can't serve as an expert witness or consultants for physicians who are being investigated by the board. They can't have ever been excluded from Medicaid, Medicare, or any other federal or state reimbursement program. They can't have had prior order from the board and never been cited by the Texas Medical Foundation or hospital for quality of care issues. So again, my shameless plug, if you have interest in becoming an expert for the board, you can email me or our panelist coordinator, Michelle Garcia, and we can certainly send you more information and appeal to physicians in virtually any specialty. Acute needs that we have at present is pain management. We also, this is the wrong group for it, but oncologists always are looking for additional, but really we're looking for anyone who has knowledge and experience and would enjoy doing reviews for the board. And that concludes my prepared talk, and I'm willing to entertain questions at this time. You've been very patient.
Hi, I have two questions. The first is, does the board make a distinction between treating people for pain with daily medications versus occasional PRN, meaning if somebody is taking 8 to 10 tablets of hydrocodone a month?
Yes. Again, the board really doesn't get into the nitty-gritty of those particular instances as far as whether or not to follow the pain management rules. If you have a patient who has chronic pain, the decision of whether or not to do urine drug screens or the pain management contracts is really going to be left up to the particulars and going to be, as I said, judged by another expert in the same field opining on whether or not that's the standard of care or not. So I don't know what the general practice is out there for those of you who do these sorts of intermittent pain, non-daily pain management. Obviously, it's always safest to err on the side of caution, but that's going to be on a case-by-case basis.
Thank you.
I wish I could give you a better answer than that.
That's okay. Thank you. The second question is, what is the current legal status, I guess, if a patient has a urine test and there is marijuana in the urine test? Okay. Is it illegal to prescribe any kind of controlled substance to that patient?
Right. It's certainly not illegal to do so. The issue is going to be whether or not, and again, I'll point it back to you, whether or not what the practice of other practitioners are to doing that. If you have a patient who's persistent, again, there's not an absolute requirement, boom, they've got a positive marijuana screen, that's it, you're not my patient anymore, I can't prescribe pain management medications for you. The expectation would be that the physician would address that with the patient and potentially lay out what the issues and problems are and also set some sort of expectations. It may not be the first time they pop up positive for marijuana, but that may increase the number of urine drug screens you want to do on the patient, and by the second or third time, if they're not adhering to what your requirements are, you might want to definitely consider discharging them from your practice.
Okay, thank you.
Sure.
So, yeah, he guessed my question behind me. What about when opioid medicines are used for non-painful conditions? Do the same rules apply?
No. As far, and unfortunately, some things fall into this, say, with cough syrup. I mean, to give an extreme example. The pain management rules don't apply unless more than 50% of your patients are getting cough syrup. You know, that's when you would have to register for the clinic. But using these controlled substances in a non-chronic pain setting, that Rule 170 wouldn't apply because you're not treating chronic pain. So let's say you're using, again, Ritalin or stimulants in an ADHD or some other setting. Even though they're controlled substances, the chronic pain rules would not kick in. If you're using controlled substances, even opioids, in a non-pain setting, those chronic pain rules would not apply.
Okay.
Now, you have a patient or patients that you have been treating for pain, and they are supposed to not have a post-fact or non-contemporaneous treatment plan, and you realize you need to have that. So how do you not have a non-contemporaneous pain
right.
plan?
So you've been treating patients for a while and then realized to be compliant with the board rules that you really needed to do a pain management contract or a treatment plan. My recommendation would be to do the best you can. For every patient you receive after that time period, have that contract in place. For those that do not have one, go ahead and establish one and document why you're establishing it non-contemporaneously. And that's the best that you can do.
I just want to ask you about two other classes of drugs that we use. One is butalbital combinations, which we may use for migraines, for example, and also hypnotics, that may be used for insomnia, for example. What type of documentation would you suggest?
Again, if you're treating them for chronic pain, need to follow those chronic pain rules regardless of really the class of substances that you're using. If you're using it for non-chronic pain issues, then our chronic pain rules would not apply. But what would apply is the standard of care of a physician taking care of that same patient. So again, that's going to be case-by-case specific, even if the pain management rules do not apply in that case. All right, you've been very patient, and I've kept you from lunch long enough. Thank you.
Be away from